sex of the patient. And it is seen in second decade of life. The age range is 7 to 19 years, and it's rarely seen after the age of 25 years. Okay. So coming to the history, as you know, history is very important to know about a tumor or any condition. You must have attended a lot of conferences and you must have seen there are quiz in all the conferences and one or two questions are always there from the history. So if you know this, you will be scoring in that quiz also. So this tumor was first described in 5th century BC by Hippocrates. And the first authentic case was mentioned by Lisson in 1841. And in 1865, Diognetus mentioned the sexual prediction of this tumor, and he reported that the tumor is exclusively seen in males. Chio in 1906 termed it as nasopharyngeal fibroma, and the JNA term, that is the juvenile nasopharyngeal angiofibroma term, was coined by Friedberg in 1940. The histopathological verification was done by Myers and Michaels in 1987. Coming to the site of origin, there has been a debate in the past for the site of the origin, but it's now accepted that the tumor arises from the upper lip of the sphenopalatine foramen at the junction of sphenoid process of palate and pterygoid process. The other site of origin is said to be Vidian canal or the pterygoid wedge. It's important to know the site of origin because it determines the pattern of tumor spread, and plus it influences the decision making for the surgical access for the removal of the tumor. So there is no definite theory of origin as of date now. That's why there are so many theories in the literature which are mentioned. So I'll go one by one, just a quick word about that. But most of the theories revolve around the ventral periosteum, hormone, vascular tissue, and fibrous tissue. All the theories revolve around that only. Verneuil in 1878 said that it's an embryonic fibrocartilage in the base of the skull which leads to this tumor. New and Kurz in 1928, they said it's a tumor of bone where chondrocranium forms the matrix. Ringers in 1938 said that the tumor originates from the ventral periosteum of the skull. And Sohm and Nepson in 1948 described that due to the unequal growth of the skull bones, the periosteum is entrapped, which gets hypertrophied due to the hormonal growth at the puberty. Hughes in 1941 mentioned it as a remnants of the craniopharyngeal duct, and Brunner in 1942 said it arises from the fascia basalis, that is fusion of pharyngeal aponeurosis and buccopharyngeal fascia at the base of the skull. Then in 1954 suggested that these growths were the result of androgenic stimulation and not the osteogenic stimulation, which was suggested earlier. Martin in 1954 said that sex hormone imbalance may have some effect on the vascularity of these tumors. Another theory by Sternberg in 1954, who suggested that vascular network has integral part of the tumor and it is a distinctive type of hemangioma. Arma in 1958 placed this tumor as the hyperplastic tissue reaction of granuloma pyogenicum or granuloma gravidarum. Now, I'll know that granuloma gravidum occurs in females during the pregnancy. Osman in 1959 considered these tumors to belong to a group of malformation of blood vessels. Schiff in 1959 hypothesized that these growths were due to an alteration in pituitary activity, that is androgen and estrogen axis. Karate et al. 1963 supported hormonal theory and showed that 17 ketosteroids and 17 hydroxyketosteroids were decreased and folliculin was increased in the urine of these patients. The most accepted theory is by Morris and Millard in 1981. They proposed that JNA is possibly a hematoma composed of combined vascular plus fibrous tissue, which simulate the erectile tissue of penis present in Carpora cavernosa and Carpora spongiosa. The points in favor of this theory are, it is the most accepted theory, and the points in favor of this theory is that both JNA and erectile genital tissue increases during period of sexual development. Secondly, both are midline, being present at the two ends of the human embryo. And histologically, both have similar pictures. So this is the most accepted theory. There are some growth factors which have been isolated in JNA, and Yardio et al. In 1993 reported a high incidence of JNA in patients with familial adenomatous polyposis, suggesting that somatic mutation of adenomatous polyposis coli gene might be associated with JNA development. And there are also increased expression of various growth factors like TGF beta 1 and insulin like growth factor IGF2, and also these are also detected in JNA during the immunostaining of the tumor. Then expression of beta catenin nuclear, c-KIT cytoplasmic, and NGF cytoplasmic are higher and more frequent in the stromal cell of juvenile nasopharyngeal angiofibroma. So coming to the blood supply, the main contribution is from the ipsilateral internal maxillary artery. Everybody knows that internal maxillary artery is one of the terminal branch of external carotid artery, and it divides into three parts. First part is before the masseter muscle, second lies over the masseter muscle, and third part is distal to the masseter muscle, and all the terminal branches supply the nasal cavity. The alternative branch which can feed this tumor is ascending pharyngeal artery, and there can be a supply from the median artery also. When the tumor extends to the opposite side or fills the choana, it can take a contralateral supply also, which may be from ascending palatine, or it may be from the terminal branch of the internal maxillary artery. When the tumor inverts the orbit, it can take its supply from posterior ethmoidal artery, which is a branch of internal carotid artery. Then intracranial JNA, when it is there, it can take blood vessels from recurrent meningeal branch of ophthalmic artery, neural branch, cavernous branch. These are all branches of internal carotid artery. And one should be careful in these cases that embolization, if done with these feeders, it can land into complication in the form of stroke or blindness. Coming to the pathology, grossly is a well-circumcised, lobulated red-purple mass with intact mucosa on the nasopharyngeal surface. The cut surface shows fibrous appearance, often with blood vessels seen at the base of the section. There are two distinct components. One is a vascular component, other is a stromal component. The vascular component has rich vascularity, and the structure of blood vessel is abnormal. The striking feature is that the muscle layer is absent. That's why these vessels do not contract when they are traumatized, and the epistaxis continue. That accounts for torrential bleed during the epistaxis. The other component is stromal component that differs in young age as well as old age. In young age, the stroma appears as loose connective tissue, highly cellular, with some collagen fibers and fibroblast in between. In older patients, collagen fibers increases markedly and become mature fibrous tissue. That's why it's easy to dissect a tumor in adult age because of the fibrous component as compared to the young population. So coming to the histopathology, there are two main cellular components in the histopathology on H&D stain, a fibrostroma consisting of spindle or stellate-shaped cells in the dense collagen matrix. This is the all collagen matrix. And then we have irregularly shaped rich network of blood vessels. These blood vessels lack a complete muscular layer, and at the periphery, you can see a pseudocapsule. These are all the blood vessels, and they are not having any muscular layer, and that is the reason for uncontrolled epistaxis. On immunohistochemistry, androgenic receptors have been demonstrated like VEGF and IGF2, and they stain very good for the vimentin also. So coming to the roots of span, after it arises from the spinopalatine foramen, the tumor can grow in any direction, and it follows the path of least resistance. So when it follows the path of least resistance, it can involve the surrounding structures. These can be described as the tumor arises from the spinopalatine foramen. Anteriorly, it can go to the nasal cavity through the ethmoids. Then posteriorly, it can go to the nasopharynx. From nasopharynx, it can go to the oropharynx. Then from Sphenopalatine foramen, it can extend superiorly to the sphenoid sinus. From there, it can go to the intracranial fossa through roof or the lateral wall. When it goes from the sphenoid sinus in the intracranial cavity, it will be medial to the carotid artery. Okay. Then from the nasopharynx, it can go to intracranial cavity through fossa of this lacerum, foramen lacerum and foramen spinosum. Then from the sphenopalatine foramen itself through cribriform plate, it can go to intracranial fossa that will go into the anterior cranial fossa. And in the lateral spread from sphenopalatine foramen, it will go to the pterygopalatine fossa and then it will go to infratemporal fossa and it can go to cheek. Then from the nasopharynx through the sinus of Morgagni, it can go into the parapharyngeal space. Then from the pterygopalatine fossa through the inferior orbital fissure, it can go to the orbit and causing proptosis and diminution of vision and diplopia. Then it through the superior orbital fissure, it will go into the intracranial fossa, that is middle cranial fossa, and it will be lateral to the carotid artery here. Okay, so this diagram shows a complete spread of the tumor from the site of origin. So clinical feature, coming to the clinical feature, the most striking feature is an adolescent male coming with recurrent unprovoked epistaxis along with nasal obstruction. Almost 80% of the cases have this history. Although it's a tumor situated in the nasal cavity, posterior part and nasopharynx, the nasal obstruction should have been the first symptom. But as the nasal cavity is not completely obstructed till a mass is of sufficient size, so minimal trauma can lead to epistaxis, and hence the epistaxis is the presenting feature. So these symptoms can increase gradually with the size of the tumor increasing. Initially, the nasal obstruction is unilateral, and when it involves both the choana, bilateral obstruction can occur. The tumor can come anteriorly into the vestibule, and it can push the septum to the opposite side, and that can also cause the bilaterally. Then there are additional features at presentation which are due to this tumor. There will be nasal discharge as there is obstruction in the posterior part of the nasal cavity. Thus, nose will be swollen because of the mass. There will be rhinodelia clausa as the nose is obstructed. Then patient will have hyposmia or anosmia. As I said, the tumor can extend to cheek, to the infratemporal fossa. There will be swollen cheek. There can be proptosis, decreased vision. There can be conductive hearing loss because of the obstruction of the eustachian tube leading to earache also. There can be headache and difficulty in swallowing. These are the additional features which the patient can have along with nasal obstruction and epistaxis. So there's a whole list of pathologies which can be differentiated from angiofibroma, but clinically it's a classical presentation. When you see a mass in the nasal cavity with prominent blood vessel and a typical history, the diagnosis is not that difficult. So diagnosis can be made on a careful history, physical examination, nasal endoscopy, and radiological study. In the history and physical examination, the typical history is present as I described earlier. That is adolescent male, unprovoked epistaxis, frequently requiring blood transfusion and packing. When you do anterior endoscopy or endoscopy, you will see a smooth lobulated mass in the nasopharynx or lateral wall of the nose. It will have prominent blood vessel over it. You can see the prominent blood vessel over it, and it just arises below the posterior end of the middle turbinate. It can be pale or purplish also sometimes with red-gray or beefy red compressible mass. On nasal endoscopy, you have to be careful not to traumatize the tumor. So you can see a slough-covered tumor here obstructing the right side of the nasal cavity. You can note down the pulsations also. There are pulsations present here. So while doing suction, you have to be careful not to traumatize this tumor. It may cause bleeding. So coming to the radiological investigation, radiology is very important for the diagnosis of this tumor as well as to plan the treatment. The radiology may involve plain X-rays, CT scan, MRI, angiogram, or the CT angiography or digital subtraction angiography. Although plain radiology is not done these days, but from academic point of view, the students should know that plain X-ray can be done. The plain X-ray might show X-ray PNS, occipitomental view may show a mass in the nasopharynx in open mouth view. There can be haziness in the maxillary antrum because of the retained secretion. There can be deviation of the septum because of the mass effect of the tumor, and there can be haziness in the other sinuses as well. On the lateral view, you can see a definite mass in the nasopharynx, and it has to be differentiated from adenoids, and that can be differentiated because you will see a air shadow in front of the adenoid rather than posteriorly. In case of angiofibroma, the air shadow will be present posteriorly if there is a space there. The other thing which you can note in a lateral X-ray is a Holman-Miller sign, which is nothing but the tumor pushes the posterior wall of the maxilla anteriorly. So that is the anterior bowing of the posterior wall of maxilla. That is called Holman-Miller sign. It can be seen in X-ray as well as in CT scan. So coming to the CT scan, CT images can diagnose GNA even without biopsy. The site of origin can be seen clearly in spinopalatal foramen. There are two constant features on CT scan which can diagnose it, the angiofibroma without biopsy: a mass in the posterior nasal cavity and pterygopalatal fossa. Second, erosion of the bone behind the spinopalatine foramen with extension to the upper medial pterygoid plate. CT is excellent for bone details that can show bony displacement as well as erosion. And on administering contrast, the mass shows avid enhancement. The CT shows invasion of the cancellous bone at the site of origin. This is very important because after you remove the tumor, you have to drill out this cancellous bone to prevent the recurrence of the tumor. In addition, the CT is helpful in staging the tumor, which can help you in planning your surgical treatment. This is the axial CT, soft tissue window with contrast. Ideally, all the three planes should be done, axial, coronal, and sagittal planes, to have a three-dimensional view of the tumor. In this, you can see a homogeneous enhancement of the tumor. Posterior part of the nasal cavity, nasopharynx, pterygopalatal fossa, infratemporal fossa. There is widening of the spinopalatine foramen, and there is extension into the nasopharynx also. And you can see the Holman-Miller sign here also. This is the posterior wall of the maxilla which has been pushed by the tumor, and you can compare it to the opposite side. The opposite side is way back. Then on coronal CT, it's a non-contrast picture. You can see a homogeneous density mass in the posterior part of the nasal cavity in the choana and into the sphenoid sinus. Then this coronal CT picture is with contrast. In this also you can see a homogeneous enhancement with the contrast. There is widening of the spinopalatine foramen. Tumor is extending to pterygopalatine fossa as well as medial part of the infratemporal fossa. Coming to MRI, MRI is superior to CT scan for detecting the intracranial extension of the tumor into soft tissue of the skull base. The lesion characteristically shows low signal intensity on T1 weighted images, and on T2 weighted images, heterogeneous intermediate signal intensity is seen in the tumor mass. When you give contrast in MRI, the images show avid enhancement with flow voids. Hello. The imaging is more important postoperatively to show any residual or recurrent tumors, and it can also monitor the effects of radiotherapy. Yes, sir. Yes. Yes, somebody calling. So this is the axial MRI T1 weighted image. It shows a heterogeneous intermediate signal, and there are flow voids present which are shown by these arrows. These represents the blood vessel in the tumor, and the tumor has extension into the nasopharynx as well as masticatory space. Then this is the axial MRI T2 weighted, again heterogeneous intermediate to high signal intensity. There are multiple flow voids within the hypervascular tumor. This is the flow void. This is the flow void. Here also flow void, and the tumor is extending into nasopharynx and pterygopalatine fossa. This is a coronal MRI with T1 with contrast. There is diffuse enhancement. You can see all white tumor, multiple flow voids of within the hypervascular mass. Again, extension into the nasopharynx and pterygoparietal fossa. This is a coronal MRI scan which shows involvement of the cavernous sinus. The cavernous sinus is involved here, and you can see the carotid artery here. Then angiography can be done by injecting contrast material into the arteries to see the feeding vessel of the tumor. Most of the time it is the ipsilateral internal maxillary artery, and it is advisable that bilateral angiography should be done in case of extensive tumors, because the tumor can have supply from other side also. And the tumor has a characteristic that it can develop its blood supply from the place wherever it goes. It goes to the opposite side, it can take the blood vessel from there. It goes in the orbit, it takes the blood supply from there. It can go to intracranial, it takes the blood supply from there. So because of the tumor angiogenic factor, that is responsible for development of the vessels wherever the tumor goes. So what are the uses of angiography? It gives you a definitive diagnosis. A tumor blast is seen, like in this case. You can see the extent of the tumor and the blood supply from which vessel it is coming. And after seeing that blood vessel, you can embolize that vessel. That will help you during surgery. And then cavernous sinus involvement can also be seen with angiography. So in nutshell, I will just enumerate all the radiological feature here. There can be a soft tissue mass in the nasopharynx, which is well circumscribed with sharply defined margins. There can be pressure erosion of surrounding bones, maybe erosion of spinoparietal foramen, erosion of floor of the sphenoid sinus, erosion of hard palate, clivus or pterygoid plates, erosion of lateral or inferior aspect of superior orbital fissure with enlargement of fissure. Then bony displacement can be there. Like I showed in the plain X-ray, there can be Hohmann-Miller sign, that is the bowing of the posterior wall of the maxillary antrum anteriorly. This can be seen in CT scan also. Then we have enlarged nasal cavity, widening of pterygomaxillary fissure, and increased distance between coronoid process and the lateral wall of maxilla. This is called Handuja sign. This can be seen in X-ray PNS as well as in CT scan. Then angiographic appearance, there is characteristic tumor blast, absence of venous filling, and there is considerable enlargement and displacement of internal maxillary artery, and there is opacification of numerous dilated vessels, which shows the vascularity of the tumor. So after the investigation, we have to stage the tumor, and like the theories of origin, we have so many systems of staging also. And I'll just enumerate all of them one by one. The first and foremost was session staging in 1981. It staged as 1A limited to the nose and or nasopharyngeal wall. 1B extension to one or more sinuses. And 2A is minimal extension to the pterygomaxillary fossa. Then 2B is full occupation of pterygomaxillary fossa with or without erosion of orbital bone. Then you have 2C, there is involvement of infratemporal fossa with or without cheek involvement. In stage 3, you have intracranial extension. So this is sessions in 1981. Then Chandler in 1984 gave another classification or the staging system. Stage 1 is tumor confined to nasopharyngeal vault. In stage 2, you have tumor extending to the nasal cavity or sphenoid sinus. In stage 3, you have tumor extending into the antrum, ethmoid sinus, pterygomaxillary fissure, infratemporal fossa, orbit, and or cheek. And in stage 4, there's an intracranial tumor. It's a very simple classification. Okay. Then we move on to the next staging system, that is the Radowski system. It has 1A tumor limited to posterior nares or nasopharyngeal vault. 1B tumor involving the posterior nares or nasopharyngeal vault with involvement of at least one paranasal sinuses. 2A minimal lateral extension into a pterygomaxillary fossa. 2B full occupation of the pterygomaxillary fossa with or without superior extension of the orbital bones. Then 2C extension into an infratemporal fossa or extension posterior to the pterygoid plates. Then 3A erosion of base of skull, middle cranial fossa or base of pterygoids with minimal intracranial extension. 3B we have extensive intracranial extension with or without extension into the cavernous sinus. So this has only 3. Then we have fish staging. According to fish, the tumor is confined to nasopharynx and negligible bone destruction or limited to spinopalatal foramen. That is stage 1. Then stage 2 is tumor invading pterygopalatine fossa or maxillary or ethmoid or sphenoid sinus with bone erosion. 3 is tumor invading the infratemporal fossa or orbit. A is without intracranial involvement. B with intracranial extradural paracellular involvement. In 4, we have intracranial tumor. A without infiltration of cavernous sinus, pituitary fossa, or optic chiasma. And B is with infiltration of cavernous sinus, pituitary fossa, or optic chiasma. So in 4, they have A and B together. Then there is a classification from All India Institute of Medical Sciences also suggested by Dr. Tandon and Dr. Sudhir Bahadur. One is tumor limited to nasopharynx, choana, nasal cavity. 2A is superior spread into ethmoids with or without proptosis due to lateral displacement of lamina papyracea or sphenoid involvement. 2B is extensive lateral spread into pterygopalatine fossa, infratemporal fossa, and cheek. 3 is simultaneous superior and lateral extension, that is 2A plus 3. Then 4 is intracranial extension. Then we have Janaki Ram staging also. It looks to me very complicated. So I am not going to mention it. It's just for your interest. You should know that there is a staging by Janaki Ram also.
Yes.
So coming to the treatment options, surgery is the gold standard for treatment. There are approaches available which are open approaches as well as endoscopic approaches. Then radiation therapy is also available, which is reserved for unresectable or life-threatening tumors. Then we have chemotherapy, which is for recurrent tumors with previous surgery or after radiations. Then hormone therapy, estrogen and anti-androgens can be used to decrease the tumor size and the vascularity. We'll discuss each one by one. So what are the principles of surgery? So you should think angiofibroma as a time bomb. Why I say that? Because it's a vascular tumor with feeders, and unless you cut those feeders, you are not going to diffuse it. Like in a bomb, unless you cut these wires, this bomb is not going to be diffused. So similarly in angiofibroma, by doing angiography, you should know what are the feeders and you have to take control of those feeders. Then only you can remove the tumor easily. So the approach should be based on the stage and site of the lesion. Surgical exposure must be adequate. Method must be functionally and conveniently acceptable to the patient. And subperiosteal dissection ensures complete removal. The moment you enter the tumor, you are going to land in trouble. You have to drill the site of origin of the tumor after removing the specimen to avoid the recurrence. As I mentioned, there can be involvement of the cancellous bone. So in surgery, we have traditional approaches like transpalatal, lateral rhinotomy, midfacial degloving, maxillary swing, and craniofacial resections. So I'll discuss them later on. First, I'll discuss the endoscopic techniques. In endoscopic techniques, we have transnasal endoscopic resection, which are for midline tumor or just a small extension to pterygopalatine fossa and medial part of infratemporal fossa, sphenoid, and medial side of the orbit. Then we have transnasal plus Denker. As the tumor goes laterally, we can increase our exposure by endoscopic Denker. Then we can combine it with a septal window or a septal dislocation. So we can go approach the lateral side of the infratemporal fossa also. Then we have forehand approach also, where the two surgeons operate with the forehand and one holds the camera, the other can provide traction to the tumor. So transnasal endoscopic technique has greatly influenced the management of GNA tumors. It has almost replaced the open techniques. Preoperative preparations are very important before you embark on doing an endoscopic resection. Pre-op embolization, hypotensive anesthesia, meticulous dissection in subperiosteal plane, and arrangement of adequate blood. I would like to add one more thing in this, that your instrumentation should also be good. And make sure that you have at least good suction machine in your OT, at least 2, because suction is very important. Then you can use the latest gadgets like coblation and navigation system to know the exact position where you are operating and whether you are leaving any tumor behind or not. All said and done, but while embarking on endoscopic surgeries, you must take a consent for open approach also, because you never know when the instrument goes at fault, and you may not be able to do the endoscopic approach. You have to open it, and sometimes the bleeding is so much you are not able to control it. You have to open it. So consent for open approach should always be taken while taking the patients for endoscopic resection. So as I mentioned, preoperative embolization is important to decrease the blood supply, to decrease the blood loss during surgery. So when we think of embolization, the question comes as, when should it be done? What is used for embolization and how it is done? So the question to when is, the embolization is to be done 24 to 48 hours before the operations. If you delay your operation beyond this period, then the tumor can develop its collaterals and the very purpose of embolization will not be achieved. So you have to plan your surgery during this period only, that you plan your embolization 24 to 48 hours before the operations. Then what is used? There are various materials which can be used to embolize the tumor. It can be gelatin sponge, it can be Teflon, gel foam, polyvinyl alcohol, silk, cyanoacrylate, sodium tetraethyl sulfate, and muscle fragments. These all materials can be used to embolize the tumor. There are two methods of doing this embolization. One is through the traditional angiography, and the other one is direct puncture therapeutic embolization. This is called DPTE. In this, what happens is you can inject the embolizing material through in the tumor itself. It can be transnasal or it can be transcutaneous under ultrasound guided or CT guided. The material injected is N-butyl cyanoacrylate plus lipodyl powder plus tungsten plus alcohol. In this, the tungsten is a special agent which colors the tumor. So when you operate, you know the margin of the tumor by that color, and you can remove the total tumor after embolization. So embolization is associated with frequent complication also. So you have to look for the feeders. If the feeders are from internal carotid artery, don't think of embolizing, because it can result into catastrophic side effects like stroke, brain and ophthalmic artery embolization, which can lead to blindness, stroke, aphasia, then facial nerve palsy, skin and soft tissue necrosis. And another common side effect is facial paresthesia, which is very common. So these complications should be in your mind before you embark on embolization. So this is a picture before embolization. You can see all the tumor blurs, and this is a picture after embolization. You can see there is no blood supply. Sorry, where it is gone. So again, it's a preoperative picture, and it pre-embolization picture, and this is a post-embolization picture, coronal views. So coming to the transnasal endoscopic resection, if the tumor is limited to the midline, then you can simply go transnasal, do a wide middle metal enterostomy. Then you can resect the middle turbinate, or if you find difficult, you can even resect the inferior turbinate, then reach the tumor, and through the wide middle maxillary enterostomy, you can take control of the internal maxillary artery or the branch of sphenopalatine artery, ligated, and you can resect the tumor transnasally. But when the tumor is bigger one, then you can switch on to other approaches like Dankers. In this, you have to expose the anteromedial wall of the maxilla, and then you resect it. You have to cut sharp the nasolacrimal duct to avoid epiphora, and ultimately you have the cavity view like this, and you can approach the posterior wall of the maxillary antrum, where you can take control of the vessels, and you can resect any amount of tumor which is there in the infratemporal fossa or pterygoparietal fossa, or going superior to the sphenoid sinus. So Danker's approach can be done for the lateral one. This is the transseptal window, where a window is created through the septum, and the endoscope or instrument can be passed through the Danker's approach, and you can see that you can resect any amount of tumor. The whole posterior wall, posterolateral wall of the maxilla is in front of you, and after removing this, whole infratemporal fossa is in front of you. The other technique can be septal translocation. In this, you don't make a window in the septum, but you dislocate the septum from the maxillary crest and push the septum on one side and pass your instruments. And later on, you can reposit the septum in the midline. So this can also serve the same purpose. Through the Denker, you can reach the infratemporal fossa, pterygoparietal fossa, and superiorly under the orbit also. So this is part of that same procedure. You can open the posterior wall of the maxilla. Then you find the periosteum there, tease out the periosteum, and under that you will find fat, and through in that will be the blood vessel, that is internal maxillary artery, and that can be clipped. And after clipping, you can simply resect the tumor without much blood loss. Then there is forehand technique, as I mentioned also. There are two surgeons operating. They have one monitor each for each, and one of them holds camera, the other holds instruments, and they can help in traction of the tumor from one side, while the other person can dissect the tumor from opposite side. So it saves time, and it's a very good approach for extensive tumor. What are the advantages of endoscopic resections? It's less aggressive to the patient. It has less morbidity, minimum bleeding, less operative time and greater efficacy, less perioperative complication, and better post-operative recovery. And the biggest thing is there is no scar of open surgeries like you see in lateral rhinotomy, Weber-Ferguson, Weber-Diefenbach, and all those procedures. The disadvantage is expensive instrumentation and expertise is a limiting factor. Plus training. You have a learning curve for this. These are the only disadvantages. Otherwise, the endoscopic approaches have replaced the open approach, surgical approaches. So coming to the traditional approaches, we have transpalatal approach, which is called Wilson's approach. This is suited for tumor limited to the nasopharynx, nasal cavity, or sphenoid. It provides a complete exposure of the lateral extension of the tumor. Now, it doesn't provide that, sorry, and it can be used in a routine manner in tumors limited to the nasopharynx. So what happens is you give an incision, curvilinear incision posteriorly on the soft palate and a horizontal incision on the hard palate. Separate the hard palate in the midline, retract it laterally. You can see the tumor there. And then you can excise. It's for small tumor. That's why the lateral extension cannot be removed with this approach. Then we have another approach that is also transpalatal. In this, we give an incision along the gingivobuccal sulcus. And then we elevate a palatal flap based on both the greater palate and arteries. Then we resect the half of the palate, hard palate, and expose the tumor and remove it. The various complications which are associated with this, almost 40% of the patient may develop palatal fistula, leading to the regurgitation of food and speech disability. Then there will be rhinolalia aperta also. Then lateral rhinotomy and other approaches. The tumor which are situated in the midline, nasal cavity, ethmoid, sphenoid, or nasopharynx, they can be removed with lateral rhinotomy. The incision given is Moore's incision. It can be curved around the ala, or it can be combined with lip splitting incision, or Weber-Ferguson incision, or Weber-Diefenbach incisions. So these are the various incisions which can be combined with lateral rhinotomy, and the tumors can be approached depending upon the lateral extent of the tumor. So the structure which are removed are frontal process of maxilla, nasolateral wall below the inferior turbinate, lacrimal bone plus lamina pepraceae, anterior and posterior model cell, and with structure which are preserved are lacrimal sacs to avoid the epiphora, nasolacrimal duct, and periosteum of the medial wall of the orbit. If you injure the periosteum of the medial wall of the orbit, it may lead to fat prolapse, and it can lead to anophthalmos also. What are the complications of these open approaches? The early complications are hemorrhage, blepharitis, lead edema, wound infection, CSF leak, and meningitis. Then there are late complications, which are crusting. Ophthalmic complications are epiphora, diplopia, and telecanthus. Then cosmetic are alar lift, vestibular stenosis, and webbing. And then facial paresthesia is also there. Another complication which can occur is frontal mucocele because of the obstruction to the facial drainage area, frontal drainage area, that secondary mucocele can form. Then surgical approach for the lateral tumors which are there in the infratemporal fossa. It's the lateral rhinotomy shown here, and lip split, medial maxillary osteotomy has been done. And then anterior maxillary segment has been removed and tumor has been exposed here. Then anterior maxillotomy is extended laterally. Spiroadmatectomy performed and posterior wall of maxillary sinus is removed for optimum exposure to safely remove the tumor from the skull base and pterygomaxillary or infratemporal fossa. And this big tumor can be removed by this. This is a large dumbbell-shaped tumor which has been removed. Then we have another approach, that is first dacrocystorhinostomy and medial canthopexis are performed. Cavity is packed with bismuth iodoform paraffin paste, and the medial maxillary segment is sutured, returned, fixed with plates, and then external and internal oral incisions are sutured. So this is the picture after this total maxillectomy approach. Then transpalatal combined with approach, that is Vege et al. In this, the medial 1/3 of maxilla is exposed and removed, including the medial wall, posterior wall, and inferior turbinate. This exposes the tumor in maxillary antrum, ethmoids, and pterygopalatal fossa. And nasopharyngeal tumor is exposed by transpalatal route. So there are mixture of two approaches, that the palatal also and maxillary also. Then there is a Sardana's approach. This is transpalatal and sublabial. This is for tumor extending to cheek, infratemporal fossa, pterygopalatal fossa, and nasopharynx. The incision given is from piriform aperture to the maxillary tuberosity. The advantage is no bone is removed, no facial deformity, and no facial scar. The disadvantage is extensive tumor manipulation may lead to ankylosis of the temporomandibular joint. This is the mid-facial degloving approach. This avoids the external scar, but we give a gingiobuccal sulcus incision. Then nasal intercartilaginous incision with transfixation incision is given. Then you can elevate it like this and then remove the anterior wall of the maxilla and into the nasal cavity lateral wall. Soft tissues are elevated. Then what are the complications of mid-facial? Facial bruising, malar paresthesia, vestibular stenosis, crusting of nasal cavity, thickening of glabella, telecanthus, heterotropia, nasal deformity because of the over removal of the frontal process of maxilla. So these are the complications which can happen after mid-facial degloving. Then we have infratemporal fossa approach without craniotomy. You can go with this approach also. In this approach, frontal branch of the facial nerve is displaced inferiorly, and then temporary displacement of zygomatic arch or temporalis muscle or mandibular condyle is done. The advantage is you have complete exposure of internal carotid artery so that you can take safeguard of that. Then we have maxillary swing. This approach requires exposure of the whole face except for the contralateral eye through a Weber-Ferguson incision, the horizontal limb of which is extended out to the zygoma. The vertical limb of the incision extends to the inner surface of the upper lip along the hard palate between the two medial incisors. It then turns laterally at the junction of hard and soft palate to run behind the maxillary tuberosity. So whole maxilla is swung laterally. So bone cuts as in maxillectomy, maxilla left pedicled on cheek flap. Then maxillary bone is swung laterally, and then maxillary artery ligation is done. Tumor is exposed and removed. Then tumor removal is done from the orbit also if it is present there through from the superior orbital fissure. Then maxilla is repositioned and fixed with the mini plates. And this is how the scar looks like in the post-op period. What are the indications of craniofacial resection? When there is intracranial extension with dural involvement, frontotemporal osteoplastic flap is elevated in this, then open craniotomy is done, tumor is mobilized from the dural attachment, then extracranial part is removed by lateral rhinotomy approach. So it's a combined lateral rhinotomy as well as frontal craniotomy. What are the advantages? There is complete removal of intracranial extension of tumor. Then there is a decreased chance of recurrence and need for postoperative radiotherapy. And disadvantages are increased morbidity, chances of profuse bleeding. Then can be dural tear, which can lead to CSF leak or CSF rhinorrhea, and there is always a risk of meningitis. Other approaches which can be used are cardiovascular enterostomy with or without Denker's modification. We have craniotomy or rhinotomy approach. We have a transzygomatic approach. We have a transmandibular approach. We have a suprahyoid transpharyngeal approach. These are also approaches which are mentioned in the literature. But as I mentioned earlier, all these open approaches has been replaced by endoscopic approach. These days, they don't see any contraindication for endoscopic removal. If it is not possible in one stage, you can stage the endoscopic resection also in 2 stages. Then gamma knife surgery, there are 2 case reports which has been there in the literature where it was used as a booster treatment for residual tumor after surgery, and no change in tumor size of one patient was seen, and in other the regression of the tumor was seen. This was reported by Dare et al. In Neurosurgery 2003. Then in Park et al. Reported 1 case of gamma knife surgery as a primary modality of treatment, and it was successful in reducing the tumor. From AIMS, there is a communication in Neurology India. They mention 19 patients with a median dose of 20 grays, ranging from 14 to 30 grays. They resulted in tumor control of 100% with a mean follow-up 77.5 months. Age range of 8 to 180 months. 1/3 of these tumors demonstrated a volume reduction after gamma knife surgery and received a prescription dose of less than 24 grays. These tumors disappeared after gamma knife radiosurgery in 15.8% of the cases. And there were no neurological complications attributed to this. This was a report from the AIMS. Then external beam radiations, the indications are extensive intracranial extension with cavernous sinus involvement or recurrent tumors. The dose is 36 to 46 grays over 4 to 5 weeks. The cure rate is approximately 80%. The 3-dimensional conformal radiotherapy in extensive GNA or intracranial extension provides a good alternative to conventional radiotherapy regarding disease control and radiation mobility. Because the external beam radiation leads to a lot of side effects, so the conformal radiotherapy is better than that. So what are the pitfalls of radiotherapy? Maxillary hypoplasia. As the tumor is in the young age, so growing age is there, so maxillary hypoplasia can occur. There can be flattening of the facial bones. Carcinoma can develop later on in 3 to 9%. The tumor can convert into angiosarcoma. It can lead to ankylosis of the temporomandibular joint, leading to trismus. There can be delayed healing, long progression time up to 3 years. Then there can be osteoradionecrosis of the palate and maxilla. There can be cataract in young patients, and there can be hypopituitarism. Coming to chemotherapy, it's not used as a sole therapy, it's only used as an alternative therapy. The indication is intracranial extension with involvement of vital structures, tumor with major blood supply from intracranial vessels. The first regime consists of doxorubicin and dacarbazine, and the second regime consists of vincristine, dactinomycin, and cyclophosphamide. Coming to the hormone therapy, it's also not used routinely, although many studies have shown that hormonal receptors are present in GNA. So GNA is a tumor with high density of androgen receptor, and application of anti-androgen like flutamide and cyproterone may represent a potential alternative to radio or chemotherapy. George A. Gates et al. 92, they first conducted a clinical trial by giving flutamide to angiofibroma patients. They treated patient with 6 weeks course of flutamide preoperatively, and the tumor size was evaluated by axial CT both before and after therapy. 4 out of 5 patients had an average tumor shrinkage of 44%. So it's important in the vital area like intracranially, when the tumor is there, if there is a reduction in tumor from the intracranial to the extracranial side, then it can be operated easily. So those cases, it can be useful. I have the personal experience of using flutamide in some cases during COVID time. During COVID time, the patient came with intracranial extension. So we started on flutamide, and later on we operated that patient. when the tumor size was shrunken. So what is the surveillance? It requires frequent physical examination. Nasal endoscopy has to be done to see the recurrence. CT scan or MRI should also be done. MRI is better to know the postoperative recurrence because of the soft tissue involvement. So what are the recurrence rates? Previously, up to 99, it has described that stage 1 and 2 has only 7% and stage 3, 39.5%. And as per the tumor size, the extracranial recurrence rate is only 5% and intracranial, it is 50% recurrence rate. Reported in laryngoscope 1986. But recently, there is a meta-analysis reported in Journal of Neurology Surgical Skull Base 2019. They say that endoscopic approach to treat JNA has a significantly lower recurrence rate when compared with open approaches. So it's very clear that endoscopic approach are the thing to go these days for tumor resection of angiofibroma. Thank you very much. This was the last slide. Thank you for your patient listening. If there are any questions, we are ready to answer it.
Very nice, Dr. Surinder. Really, thanks to you for your extremely comprehensive account of the juvenile nasopharyngeal angiofibroma, which is such a common disease to treat in every ENT surgeon's life. Before we go on to the question answer session, I have just a couple of queries from you. One is, I want to hear more about this therapeutic local embolization. What is it? It changes the color of the tumor, which helps in dissection and all.
This is nothing but the embolizing agent which I mentioned is injected locally into the tumor. It can be transcutaneous or it can be through the endoscope into the nasal cavity in the tumor mass. So
and it doesn't create any bleeding issue?
No.
It is only to color the tumor. That's the only advantage.
The tumor also, and it decreases the blood supply also. That will it causes the end arteritis and the vessels are blocked and leading to ischemia, and it colors the tumor also so that you know the margin where the tumor was. Otherwise, the surrounding tissue will merge with this.
So this is given just on the table when you are
again 24 to 48 hours. Surgery? 24 to 40 hours course.
Coming to the pre-operative embolization, Surinder, still many centers will not have the interventional radiologist and other facilities for pre-operative embolization, the high-tech procedure that we all know. Even at Loknayak Hospital, I used to take the help of my friend, Dr. Vijay Trehan, who is a cardiologist. Yes. He used to do pre-operative embolization for me, for my cases, when the radiologists were not available. So my question is, we used to do a lot of external carotid artery ligation on the table just before we start surgery. How about that?
In my experience, I have never ligated external carotid artery. And regarding the preoperative embolization, I used to do a lot. Our center was not having it. So we used to send the patient to Fortis, to the cardiologist. They used to do it. But over a period of time, I realized that it was not that helpful, because after the embolization, I found that the tumor size was increased because of the venous stasis edema. So I stopped it. Now whatever size is the tumor, I don't do embolization. My simple principle is I take control of the vessel and then dissect it.
So no embolization at all?
I don't do it.
So you are relying more on closing the feeding vessels?
Yes, definitely.
Find out the feeding vessels, finish that, and then proceed.
Yeah. And recently, coagulation has given a good advantage. It's 3-in-1 instrument. So you can resect the tumor in half also when you are not finding the proper space, so that you can reach to the blood vessel where you can control it.
How much are your anesthetists helping you in decreasing the intraoperative bleeding?
They are good.
Or you don't depend on them also?
They are good they can give hypotensive anesthesia. We put an arterial line also. Then I tell them that the pulse rate should be between 70 and not up to 70 only, not above that. Yeah. Whatever is the blood pressure, that doesn't matter.
Heart rate is more important
Heart rate
than
is more important.
the blood pressure.
Yes, sir.
Well, very nice, very nice. Please, we can go ahead. Dr. Sulba wants to say something. The moderator.
Yes, sir. Just one request to Dr. Singhal. He mentioned a BIP pack, and I don't think most of our postgraduates would be knowing much about it. So can you tell us some more uses of BIP pack?
It is a bismuth iodine paraffin pack. Basically, it was used previously to pack the mastoid cavity also.
Yes, sir.
Okay, in the nasal cavity also for epistaxis they used to do in a post-operative also. But these days nobody is using it. There are other ointments available. And regarding endoscopic surgery, people are not putting pack also these days. If you have
Yes,
achieved the hemostasis during the operation, there is hardly any need for the pack also.
yes.
And there are so many synthetic materials are also available. Like this Sinoform is available. You can inject that. No need of packing. Then intraoperatively, if there is some ooze, you can use Surgicel, you can use Flow Seal. All those things are available for hemostasis.
Thank you.
Thank you, ma'am.
So, sir, there is a question in the chat box by one of the residents. Can you repeat the routes of spread of the tumor again? And there usually most of the experts or examiners, they ask what is the spread to middle cranial fossa or anterior cranial fossa. So can you please again share the flow chart?
I show the screen.
Yes, yes, sir.
I think Raman, if the resident steal one of his slides, he has shown a beautiful picture of how it spreads. Then they will never forget.
Yes, sir explained it very beautifully. So
he should allow to get it stolen from him to the residents.
They can be. Actually, I wish I was having a skull and I could demonstrate that.
This picture I am talking about.
From spinopalatine foramen, okay, anterior spread we are talking. It goes to nasal cavity, comes through the vestibule, through the ethmoids, okay. Then posteriorly, it will go to the nasopharynx. Then from nasopharynx, it can drop down to oropharynx, okay. Then from if for superior spread from spinopalatine foramen, superiorly you see there is sphenoid sinus. So it goes there, and from sphenoid sinus, it can go to intracranial fossa. Sphenoid sinus, lateral wall erosion, it will go into the middle cranial fossa. It will be medial to the carotid artery. Okay, it can go through the roof also. Then it will be in relation to the optic chiasma or pituitary. Then from nasopharynx, it can directly go to intracranial fossa through foramen lacerum or foramen spinosum. Okay. Then it can go from spinopalatine foramen anteriorly to cribriform plate area, and by eroding that, it can go into the anterior cranial fossa. Clear? Then from spinopalatine foramen, it goes to pterygopalatine fossa. From there, it goes laterally to infratemporal fossa, and from there, it goes to the cheek. Okay. Then from nasopharynx, it can go to parapharyngeal space through sinus of Morgagni. I think everybody knows sinus of Morgagni. This is a defect in the lateral wall of the nasopharynx, period where the decent muscle is not there. Okay. So through that, it can go into the parapharyngeal space. Right. And from pterygopalatine fossa, if you see superiorly, there is inferior orbital fissure. It will enter the orbit. And from the orbit, through the superior orbital fissure, it can go into the intracranial fossa. Again, middle cranial fossa. Now it will be lateral to the carotid. Okay. So I think it explains. You can take this picture, no problem. Anybody can have a screenshot or what.
Yes.
I wish I was having a skull. I could have demonstrated in the skull where it from it is all is going.
So you'll get it in the exam. You can ask the one of the resident then.
Yeah.
Great, sir. Very well explained, sir. So thank you very much, sir, for sharing your insights and experience. I would like to request Dr. Rupender Ranga, sir, to say a few words, and then we can conclude the session.
Good evening, all the dignitaries. I am thankful to Dr. Surendra Singhal for presenting this angiofibroma topic. And after listening this angiofibroma talk, I think it is just like a child game. I'm thankful to Dr. J.C. Pasi, Dean cum Director, World Medical College, Jajjar, as a moderator of this session, and Dr. Sulva Naik from Medical College, no in this day is very popular throughout the world. And I congratulate to Dr. Professor Dr. Jagat Singh for becoming the HOD of ENT Department, PGIMS Rohtak, and Dr. Aditya Bhargav, Professor and Head of World Medical College, Jajjar. And I think next meeting on the salivary glands by the SGT Medical College, Gurgaon. And the brain behind of this whole lecture series, Dr. Raman Sharma and Dr. J.C. Pasi, I am thankful to all to update all the residents and ENT surgeon of Haryana. Thanking you all. Thank you, sir.
Thank you.
I
Thank
think
you.
we thank Madam Nayak also. She has joined first time, and I would request her to make it a regular event so that our residents can also join this program. Madam Nayak, it's a request.
I've shared the link with my residents, but maybe with an emergency, nobody has joined.
Oh, I see. Okay, in future they can join.
Yes, I always share. Some of them do join. Only today they have not joined.
Please, madam. Yes.
Thank you.
Let us request Dr. Jagat Singh also to join us more frequently now.
Yeah, definitely we will have to request him also.
Thank you, Dr.
Thank you.
Surinder.
Thank you, sir.
Thank you.
Okay.
Thank you, Raman.
Thank you,
Thank
sir.
you,
Thank
everybody.
you. Good evening, sir.
Thank you.
Thank you, everybody.
Bye.